Good day. My name is Michael Boyson, and I'm going to discuss with you some topics related to monitoring and instrumentation. I have no disclosures. Included here only for reference purposes is the American Board content outline for this topic. As you can see, the list of topics is broad and diverse. And I'll try to cover all of them superficially with an emphasis on topics of particular interest, either clinically or to the board based on past keywords. First, I'd like to address cardiovascular monitoring. With respect to the automated non-invasive blood pressure devices that we use routinely, a couple of points. One is that what we're actually measuring are oscillations as the cuff deflates sequentially. And the measured variable is the peak of oscillation amplitude, which corresponds to the mean arterial pressure. The systolic and diastolic are calculated variables. Contrast that to manual auscultation, where you're detecting the onset and offset of choric cough sounds corresponding here to systole and diastole. Now, this technique is reliable in most clinical situations, but there are some limitations. At least a small degree of arterial pulsatility must be present, and therefore patients on continuous flow pumps, such as cardiopulmonary bypass or many ventricular assist devices, will not be able to be monitored in this way. Temporal resolution relates to the fact that sudden changes will not be detected instantaneously, as each measurement requires a certain interval of time to conduct. And at extremes of blood pressure, this technique is not accurate. That brings us to invasive pressure monitoring, which is indicated really anytime the non-invasive techniques fail or when continuous real-time monitoring is desirable, either because of patient or procedure factors. The presence of an indwelling arterial cannula also affords the advantage of serial blood sampling for laboratory analysis and can provide a wealth of supplementary information. Now, looking at the morphology of the arterial waveform as the pressure wave travels from the aorta centrally to the periphery, you'll note that the arterial upstroke becomes steeper, steeper, steeper. The systolic peak becomes higher. The dicrotic notch appears slightly later, and the end diastolic pressure becomes lower. Thus, when compared with the central aortic pressure, the radial artery pressure has a higher systolic pressure, lower diastolic pressure, and a wider pulse pressure. This phenomenon is known as distal pulse amplification and has been the source of prior board questions. And it relates to the reflectance of waveforms coming back from the periphery. You'll also note a time interval, a delay in the upstroke compared to these two waveforms of about 60 milliseconds for the radial artery. Despite these differences, the radial mean correlates generally quite well with the aortic mean, although the radial mean is slightly lower, except in some disease states and often in the post-cardiopulmonary bypass period. So here we have our invasive arterial pressure tracing, and what you see is the artifact resulting from a fast flush opening the valve to the pressure bag connected to the transducer system. And this allows us to illustrate a few characteristics of the dynamic response of the monitoring system. This is not the same thing as a square wave test. the natural frequency of the monitoring system is a function of the time between these peaks, and the damping coefficient is related to the ratio of the amplitude of these oscillations. Now, I doubt you'll be asked to calculate either of these things, but it is of practical interest to know that an optimally dampened system is characterized by only 2 or 3 oscillations prior to returning to baseline after release of the flush valve. And each oscillation should be really no more than 1/3 the amplitude of the previous. So in this example, we have an underdampened system because there's more than 2 or 3 oscillations, and the amplitude exceeds 1/3 of the previous. Moving now to central venous catheterization. I've grouped the indications into broadly those that relate to monitoring and those that relate to therapy. Obviously, ultrasound guidance for central venous catheterization is something you're all quite familiar with, and it certainly is a favorite topic of the American Board. With sonographic anatomy of the IJ appearing on past keywords. For more information on that, I would direct you to this excellent article by Chris Troyanos. And I'd also like to note that the recently published ASA practice guidelines do recommend both static pre-procedure scanning and real-time ultrasound guidance during cannulation of the IJ vein. And they do mention that it can be used for the subclavian or femoral, but stop short of recommending it. The guidelines do acknowledge that this is not feasible in all clinical circumstances. Another favorite for the American Board is components of the CVP waveform. And it's very useful to have the ECG present for the purpose of orienting yourself to timing of various events in the cardiac cycle. So you'll note atrial systole, P wave, and the A wave here, and you'll note the ECG R wave corresponding to end diastole, immediately followed by the C wave, which corresponds to tricuspid valve closure and the beginning of isovolumic contraction. Again, a previous keyword topic. Now, of course, the measured CVP is profoundly influenced by pleural pressure, whether it be negative during spontaneous inspiration or positive during mechanical insufflation. So, as you see here, inspiration corresponds to the black line in both tracings, and you would want to make your CVP measurement immediately prior to inspiration or at end expiration to minimize the confounding effects of changing intrathoracic pressure. Now, a lot of information can be gleaned from the morphology of the CVP waveform, and I would just direct you to this excellent review by Pittman for more on that. This is an example of a patient with prominent A and V waves on their CVP tracing. Apologize for the glare on the monitor. Here's a better graphical illustration of the same thing. And the pearl here is that the monitor displayed value is a mean pressure, which will be falsely elevated by the presence of these large A and V waves. So in this patient, the actual CVP measurement should be made down here at the base of the C wave. And the difference can be significant. In this patient, the difference between up here and down here is 8 millimeters of mercury. Now, unfortunately, CVP is not proved useful as a measure of intravascular volume status. What you see here are 1,500 simultaneous measurements of blood volume versus CVP in a heterogeneous ICU population. And you can see there's no association whatsoever between those two variables, with some patients who have low CVP demonstrating volume overload over here, and other patients with high CVP but volume depletion. The same systematic review went on to pool trials that examined the relationship between CVP or change in CVP and stroke volume index or cardiac index. And both correlated very poorly with those measures. The area under the receiver operating curve was 0.56, with 0.5 corresponding to a coin flip, leading the authors to conclude that CVP should not even routinely be measured in critically ill patients. And you are likely not surprised by this lack of correlation, because you're aware that many assumptions exist between measuring CVP, or right atrial pressure, and the concept of left ventricular preload all the way over here. And assumptions are not the friend of anesthesiologists. But what if we could float a catheter even further through the right ventricle into the pulmonary artery and inflate a balloon such that the catheter tip is in a column of blood that's continuous with the left atrium? Maybe that would be a better marker of volume status. Well, it turns out not. Here, neither the initial wedge pressure nor the change in wedge pressure were predictive of ventricular preload as it related to trying to improve stroke volume. And again, the fatal flaw here is in all the assumptions. So our measurement of pulmonary artery occlusion pressure or wedge pressure is obviously influenced by airway pressure, mitral valve disease, and then it really falls apart here, where the relationship between left ventricular pressure and volume are not linear. In fact, it's curvilinear in a normal situation, and most of our patients have one or more of these factors influencing the ventricular fiber stiffness and thereby the pressure-volume relationship of the left ventricle. Of note, because of ventricular interdependence, both ventricles are affected. The diastolic or compliance properties of both ventricles are affected by the diastolic filling of their counterpart. A number of randomized trials in the recent past, as well as this Cochrane review, found down here no mortality benefit with a risk ratio of 1.01 associated with the use of pulmonary artery catheters. However, many of these trials have serious flaws in that they excluded the sickest patients, who ended up being managed with pulmonary artery catheters anyway at the discretion of the clinicians, thus siphoning off the patients who might actually benefit most from invasive monitoring. And to quote Michael Pinsky, why would we expect a outcome difference from a diagnostic tool unless it's coupled with an effective treatment? So clearly more studies are needed to define the efficacy of pulmonary artery catheter guided management protocols and which specific patient groups stand to benefit. So ignoring the predictive value of wedge pressure, we're left with these remaining indications for Swan-Ganz catheterization: real-time monitoring of intracardiac pressures, cardiac output measurement, and mixed venous oxygen saturations. The ASA guidelines on the subject are relatively out of date, published in 2003, and are really consensus-driven rather than strongly evidence-based. They recommend against routine use really except in the highest risk patients undergoing highest risk surgeries. The guidelines for coronary artery bypass graft patients do still recommend, as a class 1 indication, the use of pulmonary catheters in patients presenting with cardiogenic shock, and a 2A recommendation for acute hemodynamic instability, however. So what if we could measure LV preload more directly? This has been examined using transesophageal echo, measurements of left ventricular end diastolic area, which can be mathematically calculated into a volume with a number of assumptions. This turns out to be a reasonably good estimate of preload, but not necessarily preload responsiveness. As a small left ventricle can be seen in pericardial restriction, acute cor pulmonale or right ventricular dysfunction, and other conditions that cause decreased LV compliance like ischemia, infiltrative cardiomyopathy, or hypertrophy. There are values published with respect to cutoffs for a diastolic diameter of less than 2.5 or an area of less than 5.5, but those have not necessarily been replicated on further study, and I think probably present a vast oversimplification. So in summary, we discussed static measures of intravascular volume, such as CVP and pulmonary artery occlusion or wedge pressure, as well as left ventricular end diastolic area, and the significant limitations associated therein. We did not discuss IVC diameter, but that can be easily measured using either subcostal ultrasound or TEE or suprasternal transthoracic ultrasound. But again, that's really just an indirect measure of CVP, so it's subject to the same limitations as a static measure. In general, these dynamic variables, which rely on the principle of phasic changes resulting from positive pressure ventilation because of ventricular interdependence, these turn out to be better predictors of fluid responsiveness. So we'll discuss that principle briefly. Here we see a depiction of the cyclic changes due to a mechanical insufflation. So here's our positive pressure breath, airway pressure here, and you see with an increase in pleural pressure, we immediately have a decrease in right ventricular preload secondary to the increased intrathoracic pressure, as well as an increase in RV afterload. That results in a decrease in RV ejection or stroke volume. And after a couple of cardiac cycles, because of transpulmonary transit time, we see the left ventricle also experiencing decreased preload and ejection. The aortic blood velocity then reaches its maximum at end inspiration and its minimum during the expiratory period. Here we have flow probes, placed on the vena cava, pulmonary artery, and aorta, and you can see nicely here the time course of these events. So our positive pressure breath is initiated here at 1. You see a decline in vena cava blood flow, followed after a few cardiac contractions by a decline in pulmonary artery flow and aortic blood flow. These respiratory changes in arterial pressure during mechanical ventilation are more pronounced during hypovolemic states and are the basis for all of these methods of determining volume responsiveness, whether it be systolic pressure variation, delta down, pulse pressure variation. These methods are tremendously useful in the intraoperative setting under conditions of general anesthesia and muscle relaxation and controlled ventilation. However, in the ICU population, if there is any significant spontaneous ventilatory effort, they become invalid. Tidal volumes must be on the higher end, around 8 to 10 mLs per kilo ideal body weight, for this type of variation to be, for the cutoffs to be applicable. And if you have significant variability in the RR interval due to atrial fib or a lot of ectopic activity, this will also be invalidated. Interestingly, patients who have acute cor pulmonale have very afterload sensitive right ventricles, and so when transpulmonary pressure increases, you may see significant respiratory variation in both the pulmonary artery and aortic blood flows in these patients, potentially leading you down the wrong path. This would not be someone who would be volume responsive necessarily. So those are the caveats. On a related subject, arterial waveform or pulse contour analysis are integral to some of the less invasive methods used for cardiac output monitoring that we'll be briefly discussing as well. The Fick principle applies to many of the indicator injection methods, such as dye dilution or pulmonary artery thermodilution methods. However, when the term Fick method is used, it really just refers to this algebraic determination of cardiac output. So you have to measure oxygen uptake using exhaled gases from a Douglas bag, and you have to have a pulmonary artery catheter in place in order to measure mixed venous blood gas or mixed venous oxygen saturation, and therefore the venous oxygen content. And if you don't actually measure VO2, assumptions based on that may introduce significant error into this technique. Pulmonary artery thermodilution, that you're all familiar with, uses known volume and known temperature injectate injected into the right atrium, and then temperature changes are measured by a thermistor in the PA. Then the area under this dilution curve, it would be inversely proportional to cardiac output. This is pretty accurate in patients with normal or high output in sinus rhythm. But in patients with intracardiac shunts, since you're only measuring right-sided output, this becomes, does not necessarily reflect left-sided output. And in low output states, or those associated with significant TR, this becomes problematic. This can also be accomplished on a continuous basis using a thermal filament located on the catheter by the same principles. And this is really considered the reference standard and the clinical standard by which all these other methods are compared, even in the face of significant problems with it. Another favorite of the American board is the Doppler principle or the Doppler effect, which is simply that where a sound wave strikes a moving reflector, the reflected wave undergoes a frequency shift, the Doppler shift, that is directly proportional to the velocity of the reflector. This is also affected by the angle of incidence between the reflector and the sound wave, such that if they're greater than about 20 degrees, the cosine of theta introduces a significant error into this equation, as tested previously. So here we have a transesophageal, transgastric long axis view, left ventricle, aortic valve, aortic root, with pulse wave Doppler cursor across the left ventricular outflow tract. And what we've done is we've We found a single ejection here occurring after the R wave, and we've integrated the velocity of blood over one entire beat, known as the velocity time integral, or VTI. This is proportionate to the stroke volume and therefore the cardiac output. To calculate stroke volume from this, you would multiply the velocity time integral by the cross-sectional area of the LVOT, which is assumed to be constant during ejection, which may be a source of error. The other major source of error, again, is the angle theta. So if blood flow is in this direction and the angle of insonation is in this direction, this is perhaps not the best example. The same principle is used in smaller esophageal Doppler probes that are placed through the nose or the mouth, and this suprasternally directed device out of Australia, both using the same principles. This measures blood flow velocity in the descending aorta, which may not necessarily be reflective of total cardiac output, because maybe 30% of your cardiac output has already left the aorta by that level, versus at the suprasternal level, you're more proximal. Now, transesophageal or transthoracic echocardiography has a lot of advantages in hemodynamic monitoring, but is dependent on a skilled operator and your continuous presence manning the device. But it gives us a wealth of additional information related to ventricular function, filling, valvular function, wall motion. We talked about the Doppler principle, and we didn't discuss the Bernoulli principle, but you're all familiar, I'm sure, with the concept of estimated RV systolic or pulmonary artery pressure from the tricuspid regurgitant jet velocity, as well as it gives you a lot of information about extracardiac structures that may be relevant in hemodynamically compromised patients, such as the pericardium or the aorta. Another favorite of the American board is the concept of TEE views and corresponding coronary artery territories. So here we have a transgastric short axis view showing the inferior wall perfused by the right coronary artery, the inferolateral and lateral walls perfused by the circumflex artery, and the LAD really irrigates this whole anterior half of the septum all the way over to the anterolateral wall. We mentioned earlier that the arterial waveform can be analyzed to measure stroke volume and therefore cardiac output, and the general categories of devices can fall under either calibrated or uncalibrated devices, with the calibrated devices being more accurate in general. Bioimpedance is listed on the board content outline, but is an older technology that's plagued with issues in inaccuracy and probably is not acceptable for clinical use. Bioreactance represents, I think, a successful attempt to improve upon some of the problems with bioimpedance. And I think the only device that I'm aware of using this principle is the NICOM monitor, which induces an alternating current of low amplitude on both sides of the thorax with a known phase and a frequency of 75 kilohertz. And then the returning voltage is detected using these 4 electrodes here. And the relative phase shift and rate of change of phase between these signals are determined and used in the calculations of the stroke volume. The NICOM signal is correlated mainly with aortic blood volume, and since flow is the change in volume by time. The stroke volume actually correlates with the derivative of the NICOM signal in time, indicated down here. The last point with respect to cardiac output monitoring, again, to quote one of my favorite professors, there is no such thing as a normal cardiac output. There is only adequate and inadequate. And so it's important to take these numbers into view given their clinical context. The numerous methods of assessing the adequacy of end organ perfusion. We'll only discuss mixed venous oxygen saturation. So what is it? It's called mixed venous blood because it represents admixture of blood not only from the SVC and IVC, but also the heavily oxygen extracted blood returning from the coronary venous drainage. You obtain it from the pulmonary artery, such that mixing has a chance to occur from these three locations, and it's used to determine the adequacy of cardiac output. A normal is around 70%. So based on just a rearrangement of the Fick principle, basically, you see that the mixed venous oxygen saturation is affected by arterial saturation, oxygen consumption, hemoglobin concentration, and cardiac output. Therefore, a low SvO2 can only be due to one of these four things or a combination thereof. With the decreasing use of pulmonary artery catheters in the critically ill population, some attention has is now been placed on SCV, or saturation of central venous oxygen, and this can be obtained from a regular central venous catheter from which a blood gas sample is aspirated, or an oximetric catheter in the SVC or right atrium. What you see here is data from a large number of patients who had ARDS in ARDSNet trials, and the correlation between SVC, or central venous oxygen saturation, and mixed venous O2 sat is relatively tight, although there are a few cases where that's not true. In general, when the SVC sat is greater than about 70, the mixed venous sat is more than about 60. And when we are down below about 50, the SvO2 is generally quite low. This relationship is better if you put your catheter tip in the right atrium, as you might imagine, compared to the SVC. Turning now to ECG monitoring, a couple of points related to detection of intraoperative or perioperative ischemia. Older data indicated that V5 was the most sensitive single lead for detecting ischemic events, and the single lead sensitivity of V5 in this study was around 75%. We couple that clinically typically with lead 2, and that combination doesn't add much. It's only 80% sensitive. However, lead 2 gives you improved ability to detect P waves, which is another ABA favorite topic. So, and there's some newer data from this decade that indicate that probably lead V4 might be as good or better than V5. But the new and the old data agree that if you really want to maximize your sensitivity for detecting ischemia, you want to combine two precordial leads, V4 and V5, in your high-risk patients. A word about heart tones. I'm going to discuss precordial Doppler specifically in the setting of monitoring for air embolism. It's a sensitive monitor with a lower limit of detection down to less than 1 ml of air. requires a low-frequency probe at the sternal border, probably over the right sternal border in the case of monitoring for VAE, between the second to fourth intercostal space, or posteriorly between the scapula and the spine. And the early signs of air embolism are variously described as a high-pitched erratic swishing, progressing later on to the mill wheel or water wheel murmur, which is described as a splashing sound. Okay, switching gears, we're going to discuss some elements related to monitoring the central nervous system. Much of neurophysiologic monitoring is based on this principle that decreases in cerebral blood flow are associated with predictable changes in electrical signals measured at various locations. So we see here normal cerebral blood flow, 50 ml per minute per 100 gram. As it's decreased, between 20 and 25, we start seeing EEG changes. And below that, by about 15 or 13, we have isoelectric EEG. Before that point, we actually cross the infarction threshold. So at exposures of a couple or 3 hours, and at progressively shorter periods of time with further reductions in cerebral blood flow, the damage is irreversible. EEG morphology has stereotypical changes in response to reductions in cerebral blood flow, and that correlates with the severity and volume of cerebral ischemia, with the earliest changes being the loss of fast beta frequencies, followed by slowing and suppression of all frequencies. Notably, right until here, the changes are still reversible, potentially, giving us a target for intervention. Anesthetics also produce a stereotypical pattern of EEG changes, and you see how the awake EEG consists mostly of higher frequency alpha and beta waves that change with the addition of anesthetic agents. You see an overall increase in amplitude as the EEG is synchronized in the sort of 8 to 10 kilohertz range, and then that subsequently decreases with anesthetic depth. Similarly, the predominant frequencies also initially increase during the early stages, beta activation, after which the EEG shifts to lower frequency, theta and then delta waves. And then with sufficiently deep anesthesia, you see burst suppression characterized by bursts of high amplitude, activity on a flat baseline. Here we see pathways of the motor evoked potential and SSEP depicted. The muscle motor evoked potential is produced by transcranial electric stimulation of the motor cortex up here. The response then travels down the corticospinal tract, crossing the midline, in the medulla, and continues in the white matter tracts of the spinal cord, and then activates motor nuclei here in the anterior or ventral horn of the spinal cord. The response then travels via the ventral root to the neuromuscular junction, where the response is usually measured as a CMAP or compound muscle action potential. Contrast that to the cortical SSEP here, which is produced by electric stimulation of a peripheral sensory nerve here, which then enters the spinal cord via the dorsal root and ascends in the dorsal columns, crosses the midline in the cervicomedullary junction, synapses in the thalamus, and then produces a electrical activity which can be recorded over the cortex here. It can also be recorded at the level of like a peripheral nerve at a subcortical level here. Because the cortical SSEP relates to synaptical activity in the sensory cortex, SSEPs are also a good monitor for regional cerebral ischemia, but are also sensitive to anesthetic agents and changes in physiology. In the motor pathway, the primary location for synapses are in the anterior horn of the spinal cord and the neuromuscular junction, making this a more useful monitor for detecting spinal cord ischemia, particularly in the anterior spinal artery distribution. The board likes to test anesthetic effects as it relates to motor and sensory potentials and EEGs, so I encourage you to review that on your own. Now, with respect to intracranial pressure, raised ICP is very common in neurosurgical and neurological patients and can relate to head injury or hemorrhage or hydrocephalus or tumor or stroke or any number of things. The gold standard for ICP monitoring is a intraventricular drain inserted into one of the lateral ventricles here and connected to an external pressure transducer, which should be positioned at the level of the external auditory meatus. The principal advantages of this method are that it's relatively global measurement of intracranial pressure, provided that CSF can flow freely between its various pools. And it also gives you the therapeutic advantage of being able to drain CSF. The principal disadvantage of ventriculostomies are that infection is very common, and ventriculitis occurs at a rate of up to 5 or 10%. The other option is an intraparenchymal probe, shown here by B, and that uses a miniature strain gauge pressure sensor mounted at the tip of a catheter, or a fiber optic catheter could also be used, which may also enable measurement of brain tissue O2 saturation. Has a lower infection risk, but intraparenchymal probes often can't be recalibrated and have some degree of zero drift over time. And they're more limited by being a more local or regional ICP measurement, and often significant supratentorial gradients can exist, such that if the probe is contralateral to a intracerebral hematoma over here, ICP may not be dramatically or may only be modestly elevated, even in the setting of transtentorial brain herniation. Now, there is considerable controversy regarding the appropriateness of ICP monitoring in general and in severe brain trauma patients, with the most recent guidelines coming out in 2007 listing invasive ICP measurement as a level 2 recommendation in all salvageable patients with severe TBI, defined as a GCS of 3 to 8, who have an abnormal CT scan. But similar to the pulmonary artery catheter, there's no level 1 evidence, and there are negative studies or studies that show no benefit. Non-invasive methods are certainly being investigated. Transcranial Doppler shows some promise, optic nerve sheath diameter, but those methods don't replace the two standards that we discussed yet. Turning now to jugular oximetry, you can advance a catheter with the tip up here in the jugular bulb as long as you're at or above the level of C2. There is very little extracerebral contamination of this venous blood here, and you can either intermittently sample blood gas analysis or use a fiber optic catheter for continuous jugular oximetry. This jugular saturation reflects the adequacy of cerebral blood flow, at least to that hemisphere probably, or the balance between brain oxygen supply and demand. So it's affected by factors such as cerebral blood flow, metabolic rate for oxygen, and arterial oxygen content. Turning now to transcranial Doppler, this uses a handheld low-frequency probe around 2 megahertz frequency, which is also a potential test question, given that lower frequency ultrasound is advantageous for deeper tissue penetration at the expense of axial or spatial resolution. And what we're doing here is we're insunating one of the major intracranial arteries, so in this position, the middle cerebral artery, through a relatively thin temporal bone window. It's non-invasive, it's portable, but it's hard, it's highly operator dependent, and even skilled people have inadequate windows in 10 or 20% of patients. It's very useful for monitoring for cerebral vasospasm as a complication of subarachnoid hemorrhage. And that's the example that we have depicted here. So this patient has a normal right MCA mean and peak velocity. This patient here is someone with vasospasm resulting from SAH with significant, I'm not sure if you can see the scales or the numbers here, but the point is significant elevations in both peak systolic velocity and mean velocities in the MCA. It also can be used to monitor for intra and extracranial arterial stenosis, occlusion, brainstem death, and may have some role in ICP monitoring as well. Now, with respect to near-infrared reflectance spectroscopy uses wavelengths in the 700 to 850 nanometer range. As you can see, that sort of maximizes the separation between hemoglobin and oxyhemoglobin. And what we have here is we have a transmitting optode and we have 2 receiving optodes at varying distances from the transmitter. Because there's a relationship between the depth of tissue penetration and the angle of incidence of reflected light, this differential spacing here facilitates the use of a subtraction algorithm and gives us some spatial resolution. So we can sort of subtract out some of the extracerebral signal and hopefully get an indication of cortical brain oxygen saturation in this instance in the frontal cortex. So cerebral oximetry has really been embraced in cardiac surgery and anesthesia, and there's great data that cerebral desaturations are associated with postoperative cognitive dysfunction after cardiac surgery. And I just mentioned here an algorithm that can be used with brain oximetry in guiding the adequacy of brain perfusion. And this can also be very helpful in cases of complex aortic surgery, for instance, with antegrade cerebral or retrograde perfusion techniques to guide your management. The last neuromonitoring topic is awareness monitors or depth of anesthesia monitors, and these fall into 2 main categories as far as what's approved by the FDA. Auditory evoked potentials or some form of processed EEG. You're very familiar with this already, no doubt. I just would like to mention that the practice advisory does not routinely call for brain function monitoring in patients undergoing general anesthesia, either to reduce the frequency of intraoperative awareness or to monitor depth of anesthesia. and the decision should be made on a case-by-case basis. These monitors attracted a lot of interest initially and gained market share based on, I think, one flawed study. And since then, level 1 evidence has emerged that BIS monitoring is not superior to end-tidal anesthetic gas concentration monitoring, and therefore is not really routinely indicated. However, there is evidence that there's a role for processed EEG, or BIS specifically, has been studied in at least one trial. And in the Be Aware trial, a significant portion of patients were receiving TIVA. So in patients who are not able to be monitored with end-tidal anesthetic gas concentration, it probably is prudent, and there is some evidence that BIS protocol coupled with audible alarms, which is key, prevents possible awareness with recall. Turning now to pacemakers. The main categories that you'll encounter are temporary and permanent. Temporary pacing can be provided either by transvenous pacing or transcutaneous electrodes placed on the skin, and permanent leads either endocardial transvenous placement or attached to the epicardial surface, typically at the time of open surgery or minimally invasive surgery. We'll review the high-yield topics for the board, such as pacemaker nomenclature and perioperative management. Note here multiple keywords relating to this subject. Pacemaker nomenclature is standardized such that the first position relates to the chamber paced, second position, chamber sensed, third position, the response. Your options are none, atrium, ventricle, or both. Here we have I for inhibit, T for trigger, or D for dual. Such that you can have an AAI pacer. An example would be a patient who has sick sinus syndrome and intact AV nodal conduction, such that the atrium is paced, the atrium is inhibited in the case of a normal sinus beat, and VVI, indicating, for instance, a patient who has atrial fib or flutter with an inadequate ventricular response, such that the ventricle is paced but inhibited in response to sensing a native QRS complex. DDD, such that both atrium and ventricle can be paced or sensed with the response of either triggering or inhibiting, would be appropriate in a patient with third-degree heart block and a normal SA node. And the asynchronous modes, which end in OO, meaning that either we pace the atrium or the ventricle or both, but we have no sensing function and no inhibiting function. These are really only appropriate for intraoperative use or emergency pacing, with the concern here being that eventually R on T phenomenon and an unstable arrhythmia may occur. So moving forward with the clinical approach, when you're presented with patients with these devices, first priority is to determine what exactly they have. Is it a pacemaker only? Is it an ICD, which often serves as a dual role as a pacemaker, or is it a continuous or cardiac resynchronization therapy with defibrillation device, which is essentially a biventricular pacer with an ICD function. Often the medical record will shed light on this, or details can be found on the manufacturer's device ID card, and if all else fails, often an X-ray is very illuminative, and I have a couple examples of that. It's key to elicit history from the patient as to why the pacemaker was implanted and whether they're pacemaker dependent at this time. So a history of bradyarrhythmia or symptomatic bradyarrhythmia, such as syncope, Also, an EKG is very helpful to detect the presence of native ventricular beats and other historical features such as ablation in the past may clue you in as to the fact that the patient's pacemaker dependent. And then considering the surgical procedure, you have to make a determination as to whether electromagnetic interference is likely. In this example, you can see two leads emanating from the subclavian generator, and you can see one terminates here in the atrium and one continues to a ventricular position. So this would be an example of a dual chamber AV pacemaker. Often a lateral film is also helpful. In this example, on the PA projection, you can see a lead here in the right atrial appendage, apex of the right ventricle down here, and then in the lateral view, posteriorly in the coronary sinus, is the LV lead. So this would be an example of a biventricular pacer. This would be equivalent to the idea of CRT, and this would be indicated in patients who have often depressed ejection fraction and a long QRS duration, with the idea that biventricular pacing restores synchronous contraction to the heart, decreases mitral regurgitation, and improves their cardiac output. Now, in making a decision about whether the pacemaker needs to be reprogrammed, you have to assess the risk that surgery poses. So the type of cautery to be used, whether neurophysiologic monitoring, such as evoked potentials, will be used, anesthetic nerve stimulators, MRI, external defibrillation, and procedures such as lithotripsy or RF ablation or ECT are all potentially problematic. The concern is typically one of oversensing, such that the pacemaker could sense electromagnetic interference, misinterpret it as a native cardiac contraction, and inhibit the pacemaker inappropriately. And in the setting of a defibrillator, it could certainly be misconstrued as a ventricular tachycardia or ventricular fibrillation event, resulting in an inappropriate shock. Significant damage to the pulse generator is unlikely with some of these forms of EMI, but more likely with others. And it's also possible to have damage at the lead tissue interface, which would affect the patient's pacing thresholds. And it's also possible to have unpredictable responses of the device from external energy applied to it. Basic concepts of electrosurgery are that a very high frequency current is applied, alternating current, which cuts or coagulates tissue. The current density is very concentrated at the tip of the Bovie electrode, then disperses through the patient and returns to ground via the dispersive pad. So in this arrangement, a pacemaker in a left subclavian position may not be in the current arc. So the type of cautery used, as well as the location of the dispersive pad, is relevant in patients with these implanted cardiac devices. How do you tell the difference between monopolar and bipolar cautery? Well, here's an example. Monopolar cautery, much bigger source of electromagnetic interference as it relates to these devices. Whereas bipolar cautery does not rely on a dispersive pad. The current only travels from one electrode tip to the other, and therefore much lower energies are used. For further reading on the topic, I actually found this algorithm published in the British Journal of Anesthesia to be more useful than the guidelines. And so I would draw your attention to the section that deals with our our patient who has a pacemaker only, not a defibrillator, and will there be EMI associated with the procedure? If not, you're done. If yes, the key question is the patient pacemaker dependent? And your options are reprogramming versus magnet application. Last topic on electrical safety is the concept of isolated power systems. This is another favorite keyword topic. Operating rooms are certainly hazardous environments from an electrical standpoint, and in an effort to mitigate the hazard, our power systems are ungrounded or isolated, in the sense that power from the power company comes into the building and is not actually physically connected to the isolated power system, but these induction coils are involved. The relevance of that is that no current flow will occur between a person grabbing this line and standing on the ground. So it's an ungrounded power system. Now, problems can occur when a faulty piece of equipment is plugged in that then decreases the impedance from either here or here to the ground. And this may or may not result in a shock, but it's very likely to result in an alarm, given that we have these line isolation monitors. So this continuously monitors the degree of isolation, and when it detects a potential for leakage current to occur, it will alarm. And when it does so, assuming it's safe to do so, you probably want to unplug the last piece of equipment that was plugged in the operating room. That concludes my presentation. Thank you very much, and please email with questions or errors. Thanks.